interesting development made at Yale School of Medicine reveals a new trend in deadly cases of prostate cancer. Like others, prostate cancer can be easily treated if caught early, but the symptoms can be vague even then. Joining us live to tell us more is Dr. Isaac Kim, Chair of Urology at Yale School of Medicine. Doctor, welcome and happy Friday. Thanks for being here.
Happy Friday. Thank you for the opportunity.
Of course. So let's start with this new finding. This sounds really interesting. We're learning cancer deaths are decreasing, but overall cases are still going up. Tell us more.
Right. So, I think, the issue is that as the more screening for prostate cancer is being implemented, being adopted, that I think because I don't think there's a change in the incidence of prostate cancer per se. It's just we're just picking more of that. But the death number, certainly, I think, with the reflection of the accounting for the increased incidence, the rate of prostate cancer deaths is going down because that's a reflection of the new technology, better treatment options. Right now, based on the global statistics, the expectation is the prostate cancer incidence will rise somewhere around 90 to 100% over the next 25 years or so. Some of the pessimistic projections have been that because of that, prostate cancer deaths will continue to rise along with that number. What we're trying to say, based upon our statistics and our modeling, is that we think that the prostate cancer deaths actually will start going down, and to make a significant impact for three major reasons. The first is that we do think that the prostate cancer screening is going to continue to get better. This is just based upon the current the way we approach prostate cancer screening. But again, with the newer technologies such as MRIs, the so-called the micro ultrasound or a high fidelity ultrasound, that I think the prostate cancer screening will continue to improve. And second thing is the technology, right? New drugs coming on the market, different immunotherapeutic agents potentially coming on the market. So I think these are things that's going to make a huge difference in terms of improving prostate cancer outcomes. And the last, we're in the era of the AI, right? So I think the artificial intelligence is going to make a huge impact in terms of identifying who are at risk for prostate cancer or who are for the significant prostate cancer, and then allowing us to identify the most optimal, the best treatment for each patient. So I think for the reasons I remain optimistic.
Yeah, that's really interesting, Doctor. You have the uprise of AI that's helping you to detect these cases. And then of course, you have traditional screening, which I want to go back to because obviously from what you've mentioned, screening plays such a critical role in detecting these cases, which is the reason, like you just said, why we are seeing more cases. So that being said, how does one get screened for prostate cancer? How often do they need to get screened and where do they go?
Yeah. So the primary source of doctor who's make the screening for prostate cancer would be the primary doctors or the family practice doctors, the internist, and typically they'll draw a blood test called a prostate specific antigen or PSA. That's common that you hear it all over the internet. And if that test is abnormal, then certainly that patient is going to be referred to a urologist. The controversy comes around, at what age you start screening, as well as at what level of PSA, because PSA in some ways is like our height, right? For some patients, some people who that at 5 feet, let's say, would be normal, but some who's going to be at 6.5 or so, that may be normal because that's just the way the body is built, right? So each of us have a PSA that we're walking around with, and that may be perfectly normal, but we have to have a population-based data, and based upon that we have to draw an artificial line and here's arbitrarily and say at this point here anything above this number we're going to call it abnormal. So I think that, again, that is where a lot of debates have come. That being said, the most common number that we do reference in the United States is PSA 4.0, but that number again will fluctuate based upon the age of the patient. But typically we say 4.0, although again our European colleagues could have that down as low as 2.5. But somewhere around there. And then second thing is upon the age of screening for prostate cancer. Right now, the multiple guidelines suggest age 50, although I think a baseline is somewhere between age 40 to 45, especially for men who are at high risk, I think should be really seriously considered. These are patients, who have fathers, brothers with prostate cancer. as well as the African American community. I think the Black community likely needs to be screened much earlier and much more aggressively because they're at a higher risk for adverse outcomes from prostate cancer.
Wow, a lot of great helpful information there. Dr. Kim, we thank you for your time today.